Welcome to Back from the Abyss. I'm Dr. Craig Heacock. This is a place for stories of hope and healing, recovery and redemption. Today I'm doing a solo episode. This is Psychedelics, Psych Meds, and the question of tapering. Here's an interesting fact. It is very possible that you could do a more than adequate taper and washout of a serotonin med, say escitalopram. You could do it slowly enough that you don't have terrible withdrawal effects, then take a therapeutic dose of psilocybin mushrooms, which importantly have a very similar structure to serotonin. Let's say even a super heroic dose, say 6 grams or more, and then nothing happens. I've heard many versions of this story over the last few years. And to add some mystery and intrigue here, the offending serotonin meds are most often serotonin promoters, also known as agonists, not the serotonin blockers, also known as antagonists. How can this be? One of the more interesting and difficult challenges of integrating psychedelics into psychiatry is how to deal with the fact that so many of the folks who will seek out care for their treatment-resistant depression, or OCD, or body dysmorphia, or PTSD, or attachment trauma, that they're on psychiatric meds, many of which can have very significant and even dangerous interactions with some psychedelics. For the potentially millions of people who might seek out psychedelics for psychiatric treatment, or psychospiritual exploration, or just plain recreation, the question of whether to tape off some or all their psych meds is a huge issue, and one that I think merits deeper exploration. Now, we have very little data to guide us on most of the fundamental questions about med tapering. So, much like my ketamine Lessons from 3,000 Sessions episode, this synthesis today is largely based on expert opinion and represents the accumulated knowledge and wisdom of trusted underground and above-ground psychedelic therapists and guides who I've collaborated with over the last few years. Also, from many of you listeners who've shared your own experiences. And finally, from a number of my patients who have sought out their own psilocybin and or MDMA therapy in the underground. I'd like to start with a ranking of 3 of the most promising psychedelics: ketamine, psilocybin, and MDMA. I'd like to order them in terms of risk of medication interactions. So in the first slot, with the lowest risk of med interactions, by a long shot, is ketamine. Ketamine has 2 main interactions which we regularly face in psychiatry. Its subjective, dissociative, and therapeutic effects are diminished by both lamotrigine and opioids. We can compensate for the lamotrigine interaction by having patients skip 2 doses of lamotrigine prior to ketamine infusions or intramuscular treatments. But the opioid issue is more tricky, as few people are willing and able to skip a few doses of opioids prior to ketamine, and daily opioids also trigger very significant receptor downregulation, a critical issue I'll get to in a minute. In second place for relative safety with other psych meds is psilocybin. While psilocybin acts at serotonin receptors, a characteristic shared by a long list of psych meds, other non-psychiatric medications and supplements, it is, as we say, a quote-unquote clean drug, as compared with ketamine and MDMA, which are quote-unquote dirty drugs. Clean drugs have very specific targeted mechanisms and do not interact with most of the chemical systems of the body. Dirty drugs, in contrast, tend to act widely on all sorts of neurochemical systems. Now, psilocybin does its magic at one specific subtype of serotonin receptor, the 2A receptor. And it turns out that serotonin 2A receptor, also called the 5-HT2A receptor, this is where the other tryptamine, serotonin-like psychedelics such as LSD and DMT also do their psychedelic thing. So when we think about medication interactions and the question of tapering, with psilocybin, we can largely concern ourselves with this one serotonin receptor subtype. And we can separate the tapering question into 2 very different types of situations. Number 1, the patient is taking meds or supplements that are blocking the 2A receptor. These are the antagonists. And or 2, the patient is taking meds or supplements that could be activating the serotonin 2A receptor. And we call these 2A agonists. Now, any compound, whether a psych med or non-psych med or supplement that blocks the serotonin 2A receptor will tend to block the effects of other serotonin-like psychedelics such as LSD or DMT. And importantly, any compound that blocks the serotonin 2A receptor, or any receptor, will tend to trigger a process called receptor upregulation. Understanding upregulation and downregulation is crucial here. So in short, the body is always trying to maintain a homeostatic balance, perturb a physiological system, and it tends to push back. And the brain is no different. Flood the serotonin circuits with serotonin agonists, and the brain decreases the number of serotonin receptors. And if you block the serotonin circuits with antagonists, the brain produces more serotonin receptors through a process called upregulation. And while the upregulation triggered by serotonin antagonists leads to a net pro-psilocybin effect, because of the end result of an increased number of serotonin receptors to bind the psilocybin, another major challenge arises here. While I commonly hear of patients tapering off serotonin 2A antagonists and then having a powerfully therapeutic experience on psilocybin, due in part to serotonin receptor upregulation, I also regularly hear of people having terrible difficulties coming off their serotonin 2A antagonists because these meds include the widely used atypical antipsychotics, which, as Back from the Abyss listeners already know, are much better thought of as powerful antidepressants. And trying to come off meds like aripiprazole, quetiapine, lurasidone, this can lead to worsening depression and emerging suicidality, both before and after the mushroom session. So, serotonin receptor blockers can potentiate the activity of psilocybin and other tryptamine psychedelics via receptor upregulation, but washing these meds out of the brain can also lead to scary and potentially life-threatening psychiatric decompensation. Thus, a decision whether or not to taper can have heavy consequences indeed. I think it's less obvious why medications which activate the serotonin receptor, also known as agonists, or those that increase serotonin in the synapse, such as the SSRIs, I think it's less intuitive why these might be even more problematic. But consider this. The end result of increasing serotonergic activity in the brain is a downregulation or decrease in the number and density of serotonin receptors, leaving far fewer serotonin 2A receptors for psilocybin to bind with. So even if we do an adequate washout of a serotonin med, or SSRI for example, over a few days or even a week or two, the serotonin receptor density of the brain might not homeostatically shift back to normal for weeks or even months. When we plan a med taper, we talk in terms of half-lives. Now, half-life is the time it takes half of a medication to be washed out of the brain and body. The oft-cited goal for tapering is washing out a med for between 4 to 5 half-lives, which effectively means that roughly 95% of the med is out of the body. Here are a few common psychiatric meds, their half-lives, and the amount of time for 95% washout, or 4.5 half-lives. Escitalopram has about a 30-hour half-life, 5.5 days to have it 95% washed out. Fluoxetine has a half-life around a week, about 32 to 35 days for 95% washout. Aripiprazole, 75-hour half-life, roughly 2 weeks for 95% washout. For many patients, these time periods are going to be a bridge too far, attainable only with the risk of significant withdrawal symptoms and/or psychiatric decompensation. Let me work through some sample cases. I think this should help you all understand some of these concepts. Okay, here we go. Case 1. Case 1 is a 38-year-old man with a long history of scrupulosity and harm OCD. He's on escitalopram 40 milligrams the last few years with generally very positive benefit. He's wanting to do psilocybin to work on childhood neglect and attachment issues. He has no other medical problems, no other meds or supplements. He says he's happy to taper off the escitalopram to do a psilocybin session. I see at least 2 major problems here. Number 1, OCD tends to be quite chronic. And I think a meaningful taper off the escitalopram could cause a significant worsening of the OCD. But to counterbalance that, there's some really interesting anecdotal and small study open label data that psilocybin has a lot of efficacy for OCD. So that's one issue. Psilocybin might be really helpful, but coming off Lexapro, escitalopram could be difficult. The second is 40 milligrams of escitalopram. That's a big dose. He's been on that for a few years. So basically his brain has been flooded with pro-serotonin agent, which means that the serotonin receptor density in the brain of different serotonin receptor subtypes is dialed down a lot. So basically this guy has way fewer sites for psilocybin to bind. So this is the kind of person that even if he does a quote unquote adequate washout, again, for escitalopram, that would be like 5.5, 6 days. It's very possible that even with big doses of mushrooms, of psilocybin, that he would have very little benefit. So, tricky case, because clearly people with OCD are going to want to seek out psilocybin, but a lot of them are on high-dose SSRI. All right, case 2. This is a 29-year-old woman with history of profound sexual and emotional abuse by her stepfather. She takes trazodone for sleep, also takes birth control pills, triptans for occasional migraine, various supplements. Big thing that steps out here, and this was a big issue in the MAPS MDMA study too, is so many people with trauma, so many people with anxiety, so many people with depression can't sleep. So just a huge number of people who are in psychiatric care and or will be seeking out psychedelic-assisted therapies are going to be on meds for sleep. And it turns out that trazodone is a serotonin 2A blocker. Now, it has a short half-life, so it washes out quickly. But even if you have someone skip it for a night or two, you're going to have to give them something else to help them sleep. Otherwise, they're going to go into their psilocybin session deeply sleep-deprived, and that's not what you want. Case 3, this is a 65-year-old man with no apparent psych history, had a heart attack 3 years ago. He's on metoprolol, torvastatin, aspirin, followed by cardiology, no further cardiac symptoms. He runs or bikes daily, has lost 40 pounds since his heart attacks, training for a half marathon. He wants to do psychospiritual work with psilocybin. He lost a child to addiction 8 years ago and is still often paralyzed with grief. I don't actually see any major contraindications for this guy for psilocybin work. His cardiac meds do not hit the serotonin 2A receptor. So we don't have any direct problems in terms of upregulation or downregulation or blockade of the receptor. Psilocybin does raise blood pressure and heart rate a little bit, so this might be someone who you might want to start low. But interestingly, even though he has a major medical history, I don't think we're seeing anything in terms of his meds or pharmacodynamics that we need to worry about. Case 4, this is a 24-year-old woman with history of depression, doesn't want to take meds. Quote, "I tried them. I hate how they make me feel." End of quote. Has a medical marijuana card, vapes THC, quote, "I don't know how much, a lot, I think," end of quote, throughout the day, hoping that psilocybin can treat her depression. Well, this is actually a common scenario, especially in Colorado. Even though THC doesn't directly affect the serotonin 2A receptor, having THC on board with psilocybin significantly increases the risk of psychotic symptoms or psychotic break. The people I know that are working with psilocybin in Colorado are usually wanting people to take a 2 to 3 week break from cannabis or THC vapes before they do psilocybin to dial down the risk of psychotic symptoms or psychotic episode. I think another issue, and this doesn't directly relate to the topic of this podcast, but THC tends to keep people pretty stuck. You know, it's kind of a comforting blanket around the nervous system, but theoretically, ideally, if someone's doing psilocybin-assisted work, they're looking for meaningful change. And anyone who's compulsively, kind of addictively using THC, I just wonder if that person, is a good candidate for this kind of work. Case 5, our last case, 33-year-old man on bupropion, Wellbutrin for depression, He wants to use psilocybin to treat his depression and get off medication. Wellbutrin does not act at serotonin 2A, so we don't have any medication issues with this guy. What I would really want to know is what is the nature of his depression? As Dory Lewis and I explored this summer in our mushroom episode, it seems to be that certain kinds of depression, particularly depression fueled by trauma or caused by trauma, could be very psilocybin responsive. Other kinds of depression, like more endogenous or bipolar types of depression, may be much less responsive. So what's the take-home message from all of this? Get a consultation. Tapering is complicated and often destabilizing and potentially life-threatening. For people who want to do psychedelic work, it matters greatly what kinds of psychiatric problems they have and what types of meds and supplements they're taking. I focus today primarily on psilocybin since this compound is now medicalized in 2 states, Colorado and Oregon, and looks to be increasingly available in the coming years. You might be wondering about MDMA, which I labeled as a quote-unquote dirty drug at the beginning of this talk. MDMA hits lots of receptors and neurochemical systems. Its medication interactions are much more extensive than psilocybin, and the overall risk profile is significantly higher, including serotonin syndrome and seizures when combined with some meds. Also, as I've discussed on the podcast before, MDMA has a much bigger risk of post-session decompensation, even for people on no meds. Plus, it isn't yet approved for use in the US. The topic of psych meds and MDMA really demands a whole separate episode, and I'll plan to do that sooner than later. Thus, I think we can summarize that for folks with significant psychiatric illness and or on psych meds, ketamine is generally first line, followed by psilocybin, with MDMA in a distant third place. I think it's kind of ironic that ketamine, a product of big pharma, that ketamine should probably be the first step in the psychedelic-assisted therapy journey for most people. And on that note, I'll end this and encourage your thoughts, questions, comments. You can reach Chris and me through my website, craigheacockmd.com. And I was recently alerted that my website had not been working outside the country the last few months, but we got that problem fixed. So if you've been trying to reach me and you're not in the United States, try again. You can contact me directly through the website, craigheacockmd.com. All right, we'll be back in 2 weeks.